We're not just like wheeling and dealing testosterone willy-nilly. There are other labs that can help us rather than just a total testosterone. I think a free testosterone is extraordinarily helpful. I think it's much more helpful to know a free testosterone than a total. Free testosterone is where we truly see more correlation with symptom resolution. Sex hormone binding globulin is really important. Dihydrotestosterone is the one that binds with greatest affinity to SHBG. Estradiol and testosterone come in a close second place. Understanding lab values, understanding the nuance between them, what's optimal versus suboptimal, what's normal, the better your outcomes for your patients are. Hey guys, Nico Misleh here. Welcome back to the Nico Misleh Podcast. I'm hoping you're loving the last few episodes now that we have video and all that kinds of cool stuff. For those of you who are watching, I've got a couple episodes to record today, so I've got this nice big glass bottle of Sanpel, my absolute favorite. I'm not even sponsored, guys. I just freaking love this stuff. It's delicious. For those of you who are into sparkling water, man, how do you go back to drinking just flat, boring water? I get it. Europeans are right. Not about everything, but just a few things. All right, so let's get into today's subject. Today, I want to talk about labs. And more importantly, I want to kind of share with you a story of why I think labs are so important, especially when it comes to HRT. So there's two camps. There really are. There's one camp, which is, I would actually say arguably it's on the more conventional side, which is confusing. But on the conventional side of medicine, think of like NAMS and like Menopause Society and stuff like that. For the most part, I'm generalizing here. For the most part, they are not big proponents of checking labs at all. They're not a big proponent of looking at labs on an intake, at a follow-up, whatever. Obviously, this is female specific. The same can kind of be true for men in the sense that like what labs that if a, say, primary care or urologist or endocrinologist, who would be the more likely types of people to prescribe TRT if they did at all, which they hardly ever do, they will check it's just such a small amount of labs, like literally a total testosterone and a hematocrit, maybe a PSA. That I don't even know if it's all that helpful, but regardless, that's one camp. So one camp is basically zero labs at all. If any, they're sparse. The other camp is honestly, I find more on the functional medicine side, which is like way too many labs. And you guys know how I feel about functional medicine because that's kind of my upbringing there. It's way too many labs and or very complicated, very vague lab, reference ranges and assays, and God forbid we're using dried urine and salivary stuff. And I think that's way too much. The answer is in the middle. I truly believe that. And it's my, again, personal opinion, but it is also based on what literature we have, what evidence we have, coupled with my own experience in my clinic. And so I'm here to not really convince or persuade you necessarily. I just want to kind of present my observations that I have found, share with you some of the data, hopefully, and see if this makes sense to you. So why, first of all, do I not agree? Let me attack my own my own group, so to speak, the more cash-based side of things, wellness clinics, the functional medicine, integrative medicine, if you will, providers who check way too much lab work. First and foremost, I think that in many ways also takes away from the subjective observations and experiences of the patient and the provider, meaning it is super freaking important that you become an expert and a master at understanding each and every hormone and what they benefit to a human being if they are sufficient, and what detriments they create to a human being if they are insufficient, right? So if they're optimal, what do we get? If they're suboptimal, what do we get? That's really important to know. And I mean this from again, subjective analysis. What do they look like? What do your patients experience from a physical perspective that you could maybe see, right? So weight gain, maybe, fatigue, unbelievable lack of motivation and drive. Maybe they have some sexual dysfunction that they're describing to you, right? So also taking into consideration what they experience, of course. They don't sleep well. They don't recover very well. They're losing massive amounts of muscle. They're experiencing vaginal dryness. Maybe they've had a few fractures and they've never had that in their life. They're taking more falls. They're weak. These are all things, of course, that we need to be taking into great consideration. And frankly, I don't think that the conventional medicine side honestly has the time to do that. So I'm also saying that most of the time in functional medicine, because of the amount of time we have with a patient, we can get to some of those things. But what I often see is that we check so many labs, so many different types of assays and dried urine and salivary, whatever, that we now spend all our time focusing on these numbers, right? And a lot of them are numbers and assays and things of that nature that are not extraordinarily repudiated in the evidence. What do I mean by that? So let's take dried urine testing as a great example, like a Dutch test. And I've talked about this ad nauseum, but just to kind of give a reference point, most of the clinical literature, the evidence-based medicine stuff that we're looking at is via serum analysis, right? When we're doing these randomized control trials, which are very arduous and very expensive and time-consuming, we don't have time to just have every single one of our patients do a 24-hour dried urine test, which, by the way, are very expensive, extremely time-consuming, frankly, really cumbersome. They're very easy to manipulate, whether intentionally or not. If a patient fails to adhere to, not eating certain things, not drinking certain things, doing it at the right time of day. So in my humble opinion, I'm not saying that they may not have some merit. I'm simply stating that in the grand scheme of things, I find that dried urine testing or salivary testing for hormones in particular does not yield unbelievably, extraordinarily better outcomes for your patients at all, especially when compared to what I still consider to be the gold standard, which is serum. By the way, I'm like totally happy to, I have no dog in this fight, so to speak. Like I'd be totally happy to say, hey, if over the next 5-10 years, we see better data and better outcomes coming out from one type of, lab analysis than another, I'm all for it, guys. But for right now, let's just consider in the year of 2025, we should really consider that serum testing is the end all be all right now. So that's kind of the functional medicine side of things. Too much testing, way too much, too expensive, too cumbersome. Frankly, it creates just a really obnoxious barrier, I think, for most patients and even most providers, to the point at which, honestly, it's not even fun anymore or exciting. And frankly, it's not helpful. Let's compare that now to the opposite ends of the extreme, which would be like, let's just say a NAMS provider who is like, lab schmabs, we don't need them. Now, I understand where they're coming from a female perspective, so let me give the devil its due. What they're saying is, look, if you're a 57-year-old female, you haven't had a period in a year, you're experiencing all the typical signs and symptoms of menopause, so we're not discrediting their subjective experiences. It is very likely that you have a level of 0 estradiol, 0 progesterone, probably little to no testosterone. And why not just give you hormones? Now, again, I'm not speaking for all NAMS providers, but the idea that labs are meaningless and or pointless, I also don't think is very helpful. What have we seen in the literature, the clinical literature, to indicate that labs could be helpful? Number one, when we look at labs and we kind of extrapolate, relatively speaking, serum levels with outcomes, that can be a signal. So please hear what I'm saying. I'm not saying that every time we should be psychotic and obsessive about numbers, not at all. But let me add some nuance there. What I am saying is that numbers are not inherently meaningless if we see enough data. If we have enough, if we have a randomized control trial of 100,000 patients, and out of those 100,000 patients, the vast majority of them experienced better bone health protection, less cardiovascular disease risk, maybe even less Alzheimer's or something to that effect. At a serum estradiol level of, say, greater than 60 or 75, depending on the study that you're looking at, well, then that should matter. Again, we don't have to succumb to that exact number if our patients are feeling well and doing well otherwise. But what I am suggesting is that we may want to consider getting most of our patients around that specific number, because that is, in fact, where we saw the greatest amount of change in outcome. Do you see what I'm saying here? There is some value to the labs and the numbers. It's not meaningless. To be frank, I mean, this is just a freaking obvious answer, but how would we even know before we knew what menopause was? How would we even know that hormones were driving that without checking labs? And how would we know that women feel better when we give them hormones? Obviously, we could listen to their subjective experience of, oh my gosh, Nico, I'm feeling so much better ever since I started the estradiol. That's very meaningful, but that's only a subjective experience. I hope that I can trust people to give me true and honest answers. But to be frank, again, the only thing out there that I trust is God. Everybody else has got to show me some data. And subjective data is interesting, but I need some sort of quantitative data as well. And that's where labs come in. Labs are important. They're not meaningless. And I think they can provide extra value and outcomes when we look at them. We see the same with testosterone. I mean, there's a study out there that suggested that, hey, a total testosterone for a female, 150 to 350 nanograms per deciliter, we see really good outcomes. We see resolution of symptoms. And again, for a provider, that can be really helpful. We're not just guessing, right? We're not just like wheeling and dealing testosterone willy-nilly. We're actually looking for a specific number. Now, I actually take this a step further. So what I'm saying is, I actually think there are other labs that can help us rather than just a total testosterone. I think a free testosterone is extraordinarily helpful. I think it's much more helpful to know a free testosterone than a total. Free testosterone is where we truly see more correlation with symptom resolution. Generally speaking, the more optimal a free testosterone is, say, again, somewhere, in my opinion, between 3 and 7 nanograms per deciliter, we generally see greater symptom resolution. I think something like sex hormone binding globulin is really important. If you guys don't know what sex hormone binding globulin is, or SHBG, man, oh man, let me tell you, that lab, in my opinion, can really help move the needle for a lot of providers and patients where, again, we may see a male patient come into our clinic. This is a true story. Let me talk about this. Let me take a sip of my Sampel. Pardon my sip there. Let's talk a little bit about this male patient I had. I'm not going to give you his real name. I'm going to call him Greg. Greg comes into my office, 65-year-old male. He looks good, by the way. I mean, he's not in terrible shape. He's not super overweight. He exercises regularly. He's in a loving relationship with his wife, but he's got some complaints. His wiener's not working as well as it used to. He's more tired. He notices that his workouts just feel draining. Rather than I work out and then I have that kind of nice, energetic feeling and I feel really proud. He was just like, I kind of dread working out. I feel so awful after I work out. It takes me days to kind of recover. He was noticing just a real lack of drive and motivation, right? Or around some of that stuff. Sex drive was down too. And that was never a thing he dealt with ever in his life. None of those things. So he comes to me and he says, Nico, I don't feel good, but here's the crazy thing. I had my primary care check my total testosterone level. I was like, okay, well, cool, Greg. Do you know what it was? He said, yeah, man, I think off the top of my head, I think it was 9 something. And I was like, 9 or 900? He was like, no, it was the 900s. I was like, dude, Greg, that's crazy. That's a really good number for your age. Now, granted, I'm in my, what I would call my adolescent stage of HRT back in the day. I was in my 20s still. But I had just finished reading a book by Dr. Thierry Hertoff, who I credit a lot of my education from. I bought one of his books. It's a great book. It's like the Yellow Handbook, Hormone Handbook. Great book. You find it on Amazon. It's kind of expensive. But he was one of the, godfathers of HRT, coming out of Belgium, I believe. Wonderful guy. And I learned a lot from him. And my mentors did too. They were the people who kind of turned me on to him. Anyways, he talked about SHBG, or sex hormone binding globulin. For those of you who don't know what the hell that is, it's this little tiny protein that our body produces, lots and lots of SHBG, and it floats around. And its job essentially is to do two things. One, it will more or less take hostage your sex hormones, and it has a specific love affair with androgens. So dihydrotestosterone is the one that binds with greatest affinity to SHBG. And then estradiol and testosterone come in a close second place. So a very elevated SHBG is going to be really interesting. And that's exactly what I was considering with this guy, Greg. I said, Greg, if you don't mind, I know you just got some blood work done, but would you do me a favor? Will you go get some blood work done today? I have this hunch that you've got a number that's really, really elevated here besides your testosterone, your total testosterone. And I just want to see what comes up of it. So he agrees, really nice guy, goes, gets his blood work done, 48 hours later, comes back. I give him a call. And I say, Greg, I got something. I know why you feel like crap. And it is because you have low testosterone. And he was like, Nico, what the hell? Like, what are you talking about? We just agreed that my testosterone number was like insanely good. It's got to be something else. I said, well, Greg, you don't understand, man. I said, your total testosterone is great. It's 967 or whatever it was. But I checked something called a SHBG, sex hormone binding globulin number. And I described to him what that was. And I said, Greg, your sex hormone binding globulin number came back at like 95. And he, of course, asked the question, is that high? And I said, yeah, it's super freaking high. Like, it's really, really high. In optimal, and I love giving patients optimal ranges because, again, the reference range is pretty big depending on what lab you go to now. I mean, like some of them are in the 50s, 60s, 70s even on the top end. But for a otherwise healthy, young, let's just say prime of their life male patient, an SHBG should really be in the like 20s to 30s, right? Say like 25 to 35. Again, a relative optimal range. He's at 90 something. So even though he had really high testosterone levels, and it would have been really easy to agree with that primary care who checked in and said, hey, dude, I don't know what to tell you. Like, you're screwed. You've like noticed you've not a testosterone problem. You've got something else going on. What I saw was he had a very good total testosterone. He just so happened to be producing a ton of sex hormone binding globulin. And there's a couple reasons for that, especially when you're elderly. Number one, as you get older, your liver, which is where the production of that sex hormone binding globulin is really happening, starts to ramp that production up really significantly. And one of the reasons for that, I'm not going to get into this too deeply, is because your metabolic systems are starting to fail, starting to get old and starting to get sluggish. You will hear people say, oh, high SHBG is awesome. It's really good. Not necessarily. That's very nuanced too. You could also have a high SHBG because maybe you don't eat a lot of carbohydrates. There's a lot of influence between blood sugar and fasting insulin and sex hormone binding globulin. By the way, I go into like really, really deep detail about all these things in HRT University's master course. So like, I'm not going to belabor the point, but this is why I want you to be a freaking ninja and a freaking master when it comes to HRT. Because if you don't know these things, you're not going to be able to help as many patients. And it's going to not feel very good when you have poor Greg, someone like him sitting across from you, scratching his head, needing some answers, and you can't give it to him. So because I looked at labs, and not just a few labs, a handful of labs, to really help identify what the problem was for Greg, we had a really novel solution. So number one, what I found out was, even though he had a very high total testosterone, his SHBG was so high that it was consuming, it was, absolutely destroying his free testosterone, right? Total testosterone is how much gas do you have in the tank of your car. Free testosterone is how much gas is actually in the engine. I don't care if I have a half a tank or a full tank of gas. 99% of the time, if I turn my key over, the engine's going to start because there's some free gasoline up in there. It's ready to be ignited, right? It's ready to start the engine. But what happens if I have a full tank of gas, but it's being held hostage and I don't have any freaking gas in the engine of the car? I turn the key over, it doesn't start, doesn't do anything. That's why free testosterone is so important. His free testosterone was like 4 or 5, which is super, super low. What's an optimal free testosterone? Arguably speaking, 20 to 40 for a lot of guys, sometimes higher, sometimes lower. Okay. But that's a general optimal range where I find a lot of my patients feeling well at. He was 5. Okay. So again, this is why these labs matter. If we said labs don't matter, just go based off symptoms, well, okay, look, he's describing symptoms of low testosterone in one case. In another case, he's describing symptoms of major depressive disorder. Low drive, lack of motivation, decreased libido, fatigue. He's also describing symptoms of age, right? He's older. He's 65 years old. Isn't he supposed to kind of feel like that? I mean, he's not going to feel like $1 million every single day at 65. Could he be describing symptoms of metabolic syndrome? I mean, the list goes on and on. So it does actually matter when we check the labs because we can also give a more definitive answer as to what is going on. We can understand the mechanisms of action that are occurring and also give the novel solution. And when we give the solution, for example, let's just say I did not check an SHBG for Greg. And I just took Greg at face value. I said, okay, fine, dude. You have a super high total testosterone, but I'm a TRT guy. Sounds like you have low T. I'm going to give you some testosterone. How would I dose that? How would I choose to do that? Well, I don't know. I mean, maybe I would just go in at like most conventional providers do, 200 milligrams of testosterone cypionate injected once weekly, right? Would that be ideal for that gentleman? What if I did the opposite? What if I did 100 milligrams? This is even more common that I find in conventional medicine now is like, let's take the lowest dose possible, 100 milligrams once a week. Is that going to do anything for Greg? Especially to the latter one I just described, the answer is no. If I give Greg, who has a very high sex hormone binding globulin level, all these little, think of them like little Pac-Man, they're floating around your bloodstream, your serum, and I inject only 100 milligrams of testosterone cypionate for a week. His body has to use that for a week. His SHBG is going to gobble the vast majority of that testosterone up. It's going to barely budge his total testosterone number, which is also barely going to budge his free testosterone number. But again, if all you're looking at is a total testosterone, well, it might send his total testosterone to 1,200. And you're going to freak out because it's kind of high. It's off the quote unquote chart, which we all know is kind of meaningless. And again, I go into that in the course. But he's also going to say, I don't feel any better. And you're going to scratch your head. You're going to say, well, dude, I don't know if I can keep giving you more testosterone because it's already kind of high and you're not feeling any better. So it must be something else. Right? Wrong. Because we don't understand that his SHBG is super high. So he is actually going to need a bigger dose of testosterone to overcome that saturation effect that's occurring with his sex hormone binding globulin, right? We need to feed all those Pac-Man and yet have enough left over for Greg to use. So actually a bigger dose, slightly less frequent. I'm not a big fan of once a week, at least twice a week still, would be the most effective way to go forward with Greg. Do you see how complicated and nuanced this is? It's not rocket science. I mean, it's really not. You can learn this. This is not difficult. It might seem that way, but man, when you go through the course, I just break this down for you guys. I want you to be really confident and comfortable with this. But what I really am driving at is this is the importance of labs. They mean something. The problem is, in the conventional medicine world, they hardly mean anything because, of course, if you're just going between quote unquote normal reference ranges, that's not going to help you at all. And if you don't check any labs and the patient doesn't feel better, you're just going to gaslight him again and say, well, I don't know what's wrong. You're probably depressed. Let's take a female example here because I know the male ones are maybe a little bit more simple because, again, we check some men's testosterone levels. Let's talk about a female. Let's talk about that beautiful 67-year-old Betty. She comes into your office. She's clearly in menopause. I mean, she's elderly, hasn't had a period in God knows how long. She feels like crap, vaginal dryness, weakness, overweight, low muscle mass, you name it. She is a perfect candidate for HRT. By the way, she's not sleeping at all. She doesn't have any progesterone anymore, right? So she's got what she feels like is terrible insomnia. She wakes up feeling anxious. Okay. Do I really need to look at labs to be able to tell poor Betty that she is clearly in menopause and man, these hormones are going to help? No, I really don't. I really don't in many ways, okay? But again, are there numbers in the literature that do help me ensure that I'm giving Betty the best outcomes possible? Yes. What numbers? I talked about estradiol. Estradiol greater than 60 or 70, again, depending on the study that you're looking at, will, generally speaking, provide the greatest outcome in terms of preventing osteoporosis and cardiovascular disease risk. So we know that. I think that's helpful. We know that a progesterone value of at least greater than 1.0 is optimal for endometrial protection, right, in the uterus. So again, if the female has a uterus still, that would be of great value to know that. In my humble opinion, uterus is not the only important thing that we need to be protecting when it comes to progesterone. Progesterone protects the central nervous system and the brain and the mitochondria and all this stuff, man. Progesterone is way more than just a female reproductive hormone. Way, way, way more. All the hormones are, frankly. They're not just sex hormones. Okay, so absolutely there are numbers that we see that when we see them, we know that we're at least achieving great outcomes, bare minimum, the best outcomes we can. Doesn't mean that they couldn't be lower or higher, but it does mean that when we see those numbers, we're in the right direction. Here's another thing a lot of people don't talk about enough, which is seeing is believing. It just is. Okay. The only thing, I make this joke, but I don't need to see God to believe him. And that's just my personal opinion. Okay. But if you're a human being, you better show me some data. I need data. I'm a doubting Thomas if I don't see some data. If I'm a patient and you're telling me I have low hormone levels and you explain why, I just would like to see that. Okay. I'm a patient. I understand what you're saying. I believe that you're trustworthy. I believe that you know what you're talking about. You're the medical provider, of course, but I mean, long gone are the days where the medical provider is like this high priest who can just bestow health upon you and you just take it for its word. We have Google now. We have ChatGPT. Your patients can go look this stuff up and they are going to come back and have questions for you. They might look up, should I get some labs? And ChatGPT might say, yeah, you probably should. Here's why. I think you should too. I think it's of great value to our patients to not only understand and accept and listen to their subjective data, their weight gain, their fatigue, their whatever, but to also then provide some objective data and measures, and we marry those together. Hey, Betty, you know how you're not sleeping very well? Well, guess what? It's because your progesterone is 0. I'm not just saying that. I actually looked at your progesterone. Look at this. See where you were when you were 20? Now here's where you are when you're 65. Big difference, right? That is so unbelievably valuable to patients. You can't imagine. Maybe you can. I hope that you can. Because as a patient myself, whenever I've had medical stuff done, right? I don't need look, if I have a broken arm and it's obvious, let's just say my arm, you can't see me on the camera maybe, but let's say my humerus or something like that is like cut in half and my arm's like dangling all weird. Well, look, I don't need a doc to tell me that my arm is broken. I don't, but I still want an x-ray. I want an x-ray. How broken is it? Is it a green stick? Did it just kind of break a little bit halfway and it's still hanging on? Is it a full fracture? What happened? Where's the fracture exactly? Is it in a growth plate area if I'm young, right? There's so many things that imaging could tell me. Now, again, the doc could just pull me back up and put a cast on and good to go. But man, some imaging would be a lot more valuable there for both the provider and the patient, in my opinion. And I don't think lab work is that far away from that, guys. I really don't. I think it's that important. Okay. So when we look at Betty's labs and we can show her the data, we can marry her subjective symptoms with her objective results. It's just a match made in heaven. It's going to feel really good. And when we reevaluate those numbers after we've given her medicine, it will also provide us more assurance. It'll be the guide, right? It'll be again, labs are not the bullseye necessarily. They are the sights towards the bullseye. They help us narrow in on hopefully the right target, the right direction, so we can end up at a great place. Does that make sense? So think of labs, again, they're a guide, they're a signal. They're there to help us as providers, and they're there to help patients. That is the importance of these labs. I'm going to give you another really good insight here to labs. And this has less to do with hormones, actually, but it was still a hormone-specific patient. So I had a patient come in, young gal. She was, really young, like 21 maybe, when she came to see me. Perfectly normal health history. I mean as normal as a perfect health history can be, right? No major illnesses, hospitalizations, no prior issues in her entire child to now early adult life. She was totally good to go. All of a sudden, she starts experiencing severe anxiety. Like it just seems like it's out of nowhere. Seems to come around her cycles, which is interesting, of course. And okay, sounds like a low progesterone thing, right? If you guys know low progesterone symptoms and females and cycles, that would make some sense. So my head's already there. Okay, yeah. I'm listening to you. I'm hearing you. But then she starts describing what sounds a bit like psychosis, which is really startling. And she's very startled by this too. And I don't even know she quite knows it when she's describing it to me, but she describes that she's seeing things, people specifically, people that she knows aren't real, or at least she thinks they're not, but in the moment they feel very real. And they would always show up and they would talk to her. And so I'm thinking, my gosh, this kind of sounds like the onset of schizophrenia. Something to that level. And again, I had some history in mental health. I'm not a psych nurse practitioner by any stretch of the imagination. I'm not certified there, but I worked doing functional medicine to help patients with psych. And so I ran into quite a few of those patients. So, all right. So now I'm a bit perplexed. I'm like, okay, could this be like premenstrual dysphoric disorder, which is kind of leaning into this psychosis a little bit? Is her hormones that bad that it could do that? And by the way, I've seen some cases where it can get like that. But this just feels different. There's something about this case that feels different. It's so sudden. It's so strange. She's not had this lifelong thing. It's very, very recent. And so I say, okay, let's get some labs done. Let's see some other things and let's see if we can dig this up. So we get some labs done. Her progesterone's terrible. It's kind of low. It's not ideal. It's not optimal in any way, shape, or form. That seems to make sense. I replaced that for her. And she's better by 30%, right? Like the cyclical anxiety is definitely a little bit better, but her psychosis stuff is still super present. And like, dare I say worse, or it's just, if it's not better. So again, this is in my early days. I'm an adolescent nurse practitioner kind of thing, right? And I'm just like scratching my head. I'm just like, what do I do with this poor gal? She's suffering. She's telling me the truth. She's doing everything right. I mean, I've worked with her on so many different things, and so I say, okay, we need to get some more objective tests done. Why? Because otherwise, I'm just guessing. I can throw supplements at you. I can do all these different things. Certainly, you could go to a psych provider. She was already seeing. I'd already recommended her see a therapist, which was helpful, by the way. That was really great. And the episodes of her what appeared to be psychosis and stuff were not significant enough that she wanted to pursue medication. I mean, that's why she came to see me initially. Was she really did not want to go to her primary care or to a psych provider who was just going to throw a bunch of different meds at her, and I respect that. And so I send her off for more testing. Kind of typical functional med panel, right? Nothing too drastic. Again, I'm looking at some very obvious nutritional markers, a vitamin D3. I'm looking at a ferritin and iron panel. I'm looking at all these different things. So she comes back and her ferritin, the only thing that comes back that's really, really super suboptimal, like huge red flags, her ferritin. Her ferritin comes back at like 20, which again, if you're in the conventional medicine world, that's still, depending on the lab you're looking at, not low enough to like be like, oh my gosh, like something terrible is going to happen. But in the literature, we see pre-iron deficiency anemia, which is like pre-diabetes. It's just a fancy way of saying, yeah, you have diabetes. It's just we're classifying it this way. Pre-iron deficiency anemia occurs like anything below 35 or 30 on a ferritin. Okay. Her iron panel is normal, by the way, totally normal. No problem. So again, I'm not a big fan of checking iron panels because it's not that helpful. It's not the best indication of iron deficiency. Her body is pulling iron from wherever it can to stay afloat. But her ferritin comes back at 20. And so I tell this young gal, I say, hey, this is not good. I really don't like where this is at. And by the way, I pulled out into the literature. I just looked all over the place, and it was startling how many studies and case studies I found of, in particular, young women, because of course that's who suffers from iron deficiency the most, dealing with what is essentially iron deficiency anemia induced psychosis. I shit you not. Crazy how much literature is actually on that. So immediately I throw some iron biglycinate, or ferrous biglycinate, right? An iron source that is bioavailable, not please don't give people ferrous sulfate if you don't have to. That black tar they get from like a local retail pharmacy, do not give patients that. They won't use it. It tastes terrible. It's gnarly. It's horribly, strong effects on the gut where they'll end up with constipation, and they don't like it. They don't take it. I like giving iron biglycinate. Is wonderful, or iron biglycinate, depends on what brand you're looking for. That is iron, which is chelated or attached to an amino acid like glycine, which is really, really gentle, and it makes that iron even more bioavailable. It's a little more expensive, but it also works, frankly, in my opinion, like 3 to 6x times better than the other stuff. So we start her on iron biglycinate, and literally within a week, she's good to go. I'm not even kidding you. Within 1 week, she's like, Nico, the psychosis episodes have stopped completely. It's over. And I was like, you're kidding me. No, I'm good. I feel great. This is the best I've ever felt. And she was then all of a sudden describing things that she didn't even bring to my attention. Like she was like, I didn't realize how much restless leg stuff I had going on at night. I didn't realize how like unsettled I felt. I didn't realize how depressed I even felt. I felt anxious, but I didn't realize how depressed I felt. I didn't realize how slow my cognition was. That was really interesting. When she came back, her rate, the speed of her verbalization, right? Her ability to speak was faster, but like normal speed. When I had first seen her, I just assumed she talked kind of slow. You know what I mean? Hey, Nico. Yeah. Yeah, I'm doing okay. And now she comes back. She's like, oh my gosh, Nico, I'm feeling so much better. This is great. I really love the way this feels. And I'm so thankful for it. Like, it was amazing at the difference that iron biglycinate made for her on top of the progesterone. And what we really discovered, lo and behold, was that because of her low progesterone levels, we also discovered thereafter that her thyroid was a little bit insufficient. So we bolstered all of this stuff up. Again, these are all kind of interconnected. Her thyroid, her progesterone, they kind of feed off of each other. It ultimately led, with this low progesterone number to kind of a crappy thyroid number. But what really was driving a lot of her issues was her cycles, her periods rather. She was having some relatively heavy flow. And again, she wasn't very good at describing that to me initially. So my fault for not really maybe diving into that a little bit more. But this was, again, when I was an adolescent nurse practitioner. Now that I know, this is something that I drill to all my providers, all my students in the course, I say, you have to understand that low iron is one of the big red flags for females. It's huge. And again, if you're not looking at labs, and I'm not even just talking about hormone labs here, but in the panel of labs that you're looking at for your female patients, especially young female patients, if you do not add a ferritin level in there, you are going to miss out on a lot of really great outcomes. Your iron also supports your thyroid and vice versa, right? Thyroid helps prevent anemias. Iron supports thyroid function. They play off of each other. So understanding lab values, understanding the nuance between them, and this is what I give in the course, like what's optimal versus suboptimal, what's normal, quote unquote, what does that even mean? The more you can start unraveling these mysteries and feeling really confident in them, the better your outcomes for your patients are. Because again, I could have just treated this young gal with progesterone. We would have had a slight win. Like, okay, yeah, my anxiety's a little better, but I'm still freaking seeing people that aren't there. That wasn't a big enough win for me. I mean, I needed to do more for this young gal. And again, it would have been so easy in the conventional world to say, well, I don't know what to tell you. I didn't check any labs. Sounds like psychosis to me. Go see a shrink. And all of a sudden you're on, God forbid, 3 different types of psych meds. You're seeing a therapist for the rest of your life. And oh my gosh, if you end up in a psych ward, it's just this could have become a molehill, a literal molehill into a Mount Everest type of mountain, type of patient and problem, had I not looked at those labs. And by the way, I'm not the hero of the story. The patient is. Because she recognized that something was wrong, but she knew that it had nothing to do with her mental health, in the sense that, like, my brain's not broken, guys. There's something deeper here going on. And she was willing to take a bet. She was willing to take a bet on me, who would hopefully have an open mind to that and dig a little bit deeper. And by the way, it wasn't that much digging. It really wasn't. Like, what I'm also saying is you don't have to check a lab panel of like 60 or 70 different labs. Like, you can literally check 10 labs for a female patient on initial consultation and provide unbelievable data and outcomes. Unbelievable. So if this gives you guys a sense of labs versus not labs, I hope you're all leaning a little bit more towards now, hey, maybe there's some value in labs. And if I personally can't find the value in them, which is, listen, I'm not disparaging anybody who doesn't find that valuable, could at least the patient find some value there? Does it always need to be for me as the provider? Can I not provide value to the patient in different ways? Is seeing not believing? If you get hurt, if you break your arm, if your belly doesn't feel good and you think you might have appendicitis, wouldn't you rather have some imaging done or some type of objective test done to ensure that that's the problem before you get cut open into? That's how I think of it. And again, I appreciate that you might be an expert in this area. I appreciate that you've done 1,000 of these, but I'm not a part of your statistics. I'm a patient. I'm a one of one, and I want you to treat me that way, just like you, I think, would want to be treated if you were the patient and you were sitting in their shoes and sitting in that chair across from the provider. So, folks, I hope, again, that this sheds some light on my humble opinions and beliefs around labs based on the literature. I would love it if you would consider checking labs for your patients. And I think they would love it too if you don't already do that. If you don't know what labs to check, and even worse, you don't know what labs to check, and if you do check those labs, God forbid you did know, and you don't know what to do when the results come back, let me show you. Let me guide you through that. It's not hard. I promise you, it's not hard at all. You will figure it out in 2 seconds, and I will show you how to connect all these different dots. I don't want it to feel overwhelming for you or the patient. I want you to feel like a rock star. You come right in and you just click with all the things that you see. You can develop a really great care plan and plan of action. You're able to verbalize that back to your patient, right? I'm going to give you the different types of analogies, like the full tank of gas, right? Like the SHBG. I want you to be able to know those things so you can verbalize them to your patients. And I describe this in great detail in the master course, guys. If you've ever considered, man, I thought I knew enough about hormones. We'll never know enough about hormones, guys. There's always more to learn. And this course is dedicated to that ethos of learning is fun. It's interesting and it's awesome. And it only creates better competence and confidence in you as a provider. And it provides great outcomes for your patients, which, by the way, means more dollar bucks for you. And they're cheering for you. And they're going to refer 3 more patients to you because you rock and you save their life. Okay. I want that for you. So for those of you who are interested, let me know. Okay. You can comment HRT University Master Course on the podcast. If you have some questions or whatever, I'll try to answer them. But more importantly, if you really want to get in touch with me, join my daily email. It's amazing. My daily email rocks. It's called Nico's Daily. And I drop Monday through Friday, free, valuable HRT education, and sometimes even a little business education for you guys. Monday through Friday, I write them. No ChatGPT, none of that crap. Okay. It's just me. You can comment on how many things I misspell and I probably miss several punctuation marks. I can't even say the word in those emails. So it's me. Please opt in. It's under the in the show notes. And if you're listening to this on Spotify or on Apple Podcasts or YouTube, if you go to the show notes right below, you'll see Nico's daily email. Please opt in. It's totally free. And there's, I think over 1,000 providers on there now, which is crazy. I'm so thrilled. That's a great way to learn. There's a free Facebook group called Nico's HRT University if you want to hop in there too. Great way to, again, kind of see what's going on in the Nico's HRT universe and kind of meet some other providers, maybe even in your area. But last but not least, there's HRTuniversity.com, which is our website. And that's where you can find all the courses. Specifically, the master course is the one where A to Z, we walk you through all of the hormone stuff: male, female, thyroid, adjunct hormones like oxytocin and melatonin and pregnenolone and all these great things that you can be providing to your patients. I don't care what kind of clinic you have. If you're in aesthetics, if you're in functional med, if you're in primary care, HRT is not fringe anymore, guys. It's foundational. Learn it. If you don't learn it, these patients are going to go somewhere else and you're just losing money in patients. Okay. So learn this stuff, guys. HRTuniversity.com. Check out the master course and let me know what you guys think. If you join into the master course, please introduce yourself in the community. I love that. Share a picture of yourself. If you want to add your family, you can. Tell me all about you. Tell other providers about you. It's a really fun place to hang out. We have a really low cost membership right now for all my founding members. Okay. So it's $29 a month. You get weekly Q&A calls with me for an hour. I mean, I charge like $500 an hour for consultation. I do this for like $29 a month. You can have 1 hour with me and a bunch of other providers going through questions about the course, case studies. We even talk some business stuff in there if we have time. It's really, really fun. You'll have access to a great community. There's also some private videos that I drop in there and go into some deeper dives on some different subjects. So very worth checking out. All right, guys. I think this is enough blabbing for today. I need some more Sam Pell. It's early. I got another podcast episode to record, so I will catch you all later. Thank you so much for listening and see you next time.